So, good morning to all. This is today's topic is on induction of labor. I'm Dr. Shweta Patel, additional professor at AIMS Bhopal. So, prior to go in the topic, first just a brief about what is induction of labor. As the definition implies, the artificial initiation of uterine contraction in a quiescent uterus by any method like a medical, surgical, or combined prior to their spontaneous onset and before the period of viability, beyond the period of viability. So, what is induction? Induction is the initiation of uterine contraction. That is, these are basically the artificial, either as the medical method or any surgical or a combined method by which we initiate the uterine contraction once the viability is achieved. And what is the difference between induction and augmentation of labor? So what is augmentation of labor? That is, already labor is occurring. That is, a naturally contraction is occurring at the term and we are augmenting, increasing the intensity of these contraction by any of the pharmaceutical agent. These are basically accelerate the process of labor. Normally we use the oxytocics for the augmentation of the labor. So in the induction of labor, what are the recommendations? So there are some WHO recommendations, that is, induction of labor should be performed only when there is a clear medical indication for it and the expected benefit is outweighed the potential harm. That means there should be some indication. Otherwise, we all know that there is always a delivery occur at term. So we are we are actually initiating the contraction earlier. So there should be some indication, and that indication is a beneficial for the mother as well as to the fetus. And in applying the recommendation, consideration must be given to the actual condition, wish or the preference of the women, and emphasis being placed on the cervical condition. The specific method of induction of labor and associated conditions such as parity or rupture of membrane should be noted when we are planning for induction of labor. Induction of labor should be performed with the caution, since the procedure always carries a risk of hyperstimulation and there even a risk of rupture of the uterus. Wherever induction of labor is carried out, there should always be availability of facilities for maternal and fetal well-being. Women should never be left unattended. There could be a failed induction. The induction always be performed in a place where cesarean facilities will be available, and if it is failed, that carried out in a facility where cesarean section must be done immediately. So what could be the setting where the induction of labor be performed? That means we are now initiating artificially the labor. So what could be the setting? This is not at a home the patient can be given the induction drug. This induction always be performed in a setting where the maternal and fetal condition should be monitored. So all the patients should be admitted for the induction of labor. The one most important criteria is prior, once you identify that this patient or this pregnancy is now harmful to the mother or fetal, it will be carried forward. So we are planning a induction or now deliver this type of a fetus. So these are the patients should be identified in your OPD, and these are all the patients should be admitted in where the health facility having the availability of cesarean section 24/7 available. Induction of labor should done under necessary supervision and maternal and fetal monitoring, and the progress of labor should be charted properly. So what could be the prerequisite? What are the prerequisite and pre-induction assessment? Once we identify this is a patient where the induction is required, the some pre-induction assessment or requisite are, first of all, we always have to take a informed consent. We always have to review the maternal history. So these are actually the prerequisite we follow in our labor room. है ना? In our OPD, antenatal OPD, we identify the patient. That means we are identifying the indication and then we are advising the admission and refer to her to the labor room. The assessment occur in the labor room where you have to take an informed consent, review of maternal history and profile, evaluation of the induction, and again the rule out any contraindication. Always re-estimate the gestational age, presentation and fetal weight prior to the induction. Then the recording of the vital of the patient and evaluation of the fetal heart rate by the NST. So these are the prerequisites prior to induction of labor. Maternal pelvis assessment, assessment of cervical status and indication for induction and gestational age along with the modified Bishop score. These all points should be noted at the time of admission. So, we all know that there is indication of induction of labor. So, what are the indication? All indication when benefit to the mother or fetus outweigh the continuity of the pregnancy. है ना? That are the time where we plan a induction of labor. So what are those induction indication where we plan the induction? The most accepted absolute indications are, the most common is hypertensive disorders in pregnancy, in which the preeclampsia and severe preeclampsia are the patient where we plan the induction. Other are maternal medical condition like a gestational diabetes mellitus or uncontrolled diabetes, type 2 diabetes or gestational diabetes mellitus, renal disorder, chronic pulmonary disorder, pre-labor rupture of membrane, cases of chorioamnionitis, fetal growth restriction, RH isoimmunization, oligohydramnios where the Likert is less than a 5, where there is a IUFT or intrauterine fetal demise, or when the pregnancy is prolonged, that is a post-term pregnancy more than a 42-weeker pregnancy where we plan induction of labor. So these are absolute indications. What are the relative indication? Relative indication means when the benefit is more but it could or couldn't be where the induction is applicable. This is not absolute a treatment of a particular disease. These are the some relative indication. What those? These are the like a chronic hypertensive patient. Other systemic medical disorder like a SLE, like a hypercoagulable disorder, cholestasis of pregnancy, some polyhydramnios cases, fetal anomaly cases, history of previous stillbirth where we want to deliver the patient prior to that particular time where the recurrent IUDs occur, and the postpartum pregnancy. Sometimes there are the multiple factors where we plan a induction of labor. What are the contraindication of induction of labor? So this even we have an idea. What are the contraindication? Absolute contraindication are previous uterine scar of hysterectomy, classical cesarean delivery, or where is a repair of uterine rupture. So wherever the incision or repair of upper uterine segment occur, these are absolute contraindication of induction of labor. Why? Because upper uterine segment or the body of the uterus is the area which act where the muscle are actually contracting. So there are the very high chances of rupture of the uterus, spontaneous rupture of uterus. So this is an absolute contraindication. Other are the active genital herpes, placenta previa, umbilical cord prolapse, transverse lie, and the CPDs. So these are actually the absolute indication of cesarean section. Other relative contraindication of induction are like a cervical fibroid, severe cardiac disorder, malpresentation like a beach, and non-reassuring fetal heart rate. So there could be the may or may not. Sometimes we prefer the induction in these patients, but majority of these are actually where the cesarean is needed. So these are the indication. Now till now, what we know, what is induction, what is prerequisite, what are the indication of induction of labor. So prior to the induction of labor, we should have an idea what is cervical canal and what is a birth passage. So we all know that the when the induction is occurring, there is a dilatation of the cervix, softening and the dilatation of the cervix. Prior to the actual contraction, there is a ripening of the softening of the cervix. So what is cervical ripening? A prelude to the onset of labor where the cervix becomes soft and compliant. This allows its shape change from being long and close to being time out, effaced and even dilated. So that long closed firm cervix become little softer, and there are the start of dilatation occur prior to the labor. So this we call as a cervical ripening stage. It occur naturally or a result of physical or pharmacological intervention. So these are the area, the cervical ripening with the uterine contraction are actually the aim of a induction of labor. So if we want to know what is actually the cervix, why it is so firm, we have an idea. The cervix is made up of cellular and the extracellular tissues. The cellular is basically the smooth muscle cell and the fibroblast, and the extracellular components are collagen, elastic, proteoglycan and chondroitin. So when there is a ripening, there is actually the hydrostatic action, loosening of these collagen fiber, and ultimately the cervix becomes soft. Pre-induction cervical ripening. So what is this? The cervix becomes soft. Prior to induction of labor, to know the success of labor, what is required? We require the condition of the cervix. We all know that if something is very tight, it is difficult to open it. But if we ripen it or there is a some softening it, then it is easily stretchable and it become open. The same applicable to a cervix in the any induction of labor. So to assess the success of any induction of labor, we always want to know the condition of the maternal cervix. For that, we do the examination, per vaginal examination, and we want to know the condition. So there is a score, that is a Bishop score is available to know the condition of the cervix. This is Bishop score. Bishop score actually uh, have a 5 important parameter. These are the 4 are the cervical parameter and 1 that is a fetal station of the fetal head. So what is this Bishop score? For the cervix, there are the important point like the cervical dilatation. So firstly, prior to induction, when we do the vaginal examination, we want to note these all cervical finding. What is dilatation of the cervix? What is effacement of the cervix? Consistency and the position of the cervix. So what are all these 4 points? Dilatation means how much dilate is cervix, how much opened up is the cervix. Effacement means how much is the length of the cervix. So one is the width and one is the length. Then the cervical consistency. If you touch the cervix, how it feel? Is it a firm, medial or absolutely soft type of a feeling? Then position of the cervix. Once we enter the our vaginal finger, middle finger inside the vagina, if it is just touch the cervix, that means it is a mid position, or it is a posterior or anterior cervix. So these 4 cervical points we want to note prior to induction of labor, And the last point is the station of the fetal head. Along with this, we even want to palpate the fetal head. Is what is a station? So this you all read in your uh, labor, progress of labor. So there is, with respect to the ischial spine, there is a different station. There is a -3, -2, -1, 0, +1, +2. These are the given to with respect to the dipping of the fetal head into the maternal pelvis. So these 5 points is included to calculate the Bishop score, and they had given a particular number 0, 1, 2, 3 number for the calculating the Bishop score. The maximum Bishop score is 13 and minimum Bishop score is if the Bishop score is less than 6, it is non-favorable. If it is a more than 6, that means it is a favorable. That means the cervix is soft and it is little dilated and there is a good chance of uh, having a vaginal delivery if we plan a induction in these type of a patient. So in a Bishop score, there is a effacement is used in term of percentage, and it is difficult to calculate the percentage by using the Bishop score. So in the later on, there is a modification in the Bishop score. So what is a modification? In the modification, instead of percentage of effacement, there is a length of cervix is included. The purpose is same. The this representation is the same, but it is a more objective type of a score where we noted the length of the cervix in place of the percentage of effacement. So if it is given again a 0, 1, 2, 3 number, that means the highest the length, the lowest the number. Opposite to the dilatation, more the dilatation, more the number. Ultimately, what we required at the time of delivery, dilatation should be good, effacement should be maximum, that means the length should be minimum, the cervix should be soft, station is as low as possible, and the position is either mid or anterior. These points are actually the favorable point. So what we require, we firstly calculate these all points and we have an idea how much could be a success of this type of a induction, so that we can give a good counseling to the mother and we can even assume that how much dose of induction drug is required in that particular patient. So this is a Bishop score. Even though we had a good score, there are the other predictive factor to know the success of a induction of labor. What are those predictive factors? Like a period of gestation. We all know at term there is a spontaneous formation of lower segment and there ripening of the cervix. So at term there are the more chances of successful induction rather than a preterm patient, preterm gestation. Then pre-induction score I already described. Sensitivity of the uterus. Sometimes some oxytocin challenge test is given to note the how much is the sensitivity, but it is not at all done in a nowadays. Then the these are the other like a maternal height, BMI and fetal weight. If the less is the fetal weight, there are the more chances of vaginal delivery. So they are the some objective predictor to note the success of any induction of labor. The last and the most modernized predictive indicator of induction of labor is a ultrasound imaging. In the ultrasound, basically we want to note the cervical length, and if the more objective and accessible the entire length of the cervix. So in the ultrasonography, the length, internal cervical os, shape and assessment of angle between the cervical axis and wall of the inferior uterine segments are measured. But these are all basically a research point of important, theoretically important, but practically there is no such evidence to show any benefit of assessing the or using a ultrasound imaging to predict the success of induction of labor. Now, what are the available agents for induction of the labor? So we all know what how we assess the cervical parameter. So there are the some available agent are non-pharmacological agent and the pharmacological agent. Non-pharmacological agents are the historical agent used in a ancient time. Nowadays we have a very good pharmacological agent and rarely we use these type of a non-pharmacological agent. So herbal supplement like a evening primrosa oil, blue black bushes, raspberry leaves were used in a history to induce the for the cervical ripening or induction of labor. Then there are the breast stimulation. Their history has the role of breast stimulation, which uh, causes the oxytocin release and it causes the augment or initiation of uterine contraction, and there the delivery will occur. Then the role of castor oil. Castor oil is actually a laxative which is used for the which causes a bowel irritation and ultimately leads to the initiation of uterine contraction and induction will occur. Some other miscellaneous non-pharmacological agents are acupuncture, sexual intercourses, which can even initiate the uterine contraction. Hygroscopic dilatate, these are actually the very good non-pharmacological agent for induction of labor, which sometime in a very high risk patient, especially for the early abortions, used uh, um, mm, are used like a laminaria tant. Laminaria is a plant wood which has a very good hygroscopic action, and this ultimately swollen and slowly it causes a dilatation of a firm cervix. So in a term the cervix become actually very soft, but in a mid of the gestation like at around 20-24 week it is a very firm cervix, and sometimes induction of labor actually the applicable to a term gestation, but sometimes induction of uh, is terminology is applicable or these agents are even used for the abortion as well. So laminaria tant is a method which is used for the abortion purpose mostly. Nowadays, it is not at all used for induction of labor. Then the other non-pharmacological like a membrane stripping. What is that membrane stripping? At the time of pervaginal examination, especially when there is a little bit dilatation of the cervix, especially in a multipara patient. What we do, we insert the our vaginal finger and little bit sweep the finger and try to strip the amniotic membrane. This causes a release of the prostaglandins and ultimately it stimulates the uterine contraction. Result in a less labor induction, less postdated pregnancy and more spontaneous onset of labor. So at near to term, sometimes the patient become post term and there is a load to the labor room. So to reduce that load, these are the ancient method which is used where we strip the membrane and this causes a induction of or initiation of uterine contraction. Then the balloon devices. These are the Foley's balloon which insert into the cervical canal and we infiltrate the bulb of these Foley's with the normal saline. Around 30 cc of normal saline is used to inflate the bulb of the Foley's, and then this inflated bulb and the Foley's is stretched and tied over the thigh of the maternal maternal thigh. This causes a little bit pressure over the internal os, and there is both the mechanical and slightly stripping of the membrane ultimately leads to the initiation of uterine contraction. So is a very good in a patient where there is a posteriorly uneffaced long cervix where the pharmacological agent if we use leads to the more uterine contraction rather than the ripening of the cervix. This balloon method causes a good softening and dilatation of the cervix. Once we use the balloon method, the cervix become ripen, and then we initiate our pharmacological agent for initiation of uterine contraction. So both the method combine together and further enhance the success of our induction of labor. The last non-pharmacological method is the amniotomy. What is amniotomy? We cut or we a simple and effective method where the membrane are accessible and the cervix is favorable. It creates a commitment to the delivery. Flow of amniotic fluid should be controlled with the vaginal finger, and it done in under in an engaged presentation. Simultaneously, amniotomy will assess the liquor color. That means it is a clear liquor or it is a meconium stained liquor. So this amniotomy is a good method where there is a fetal anesthesia showed little non-variability and there is a abruption, and with the poor maternal condition we even try a induction of labor by doing the amniotomy. This causes a release of prostaglandin and ultimately causes a initiation of uterine contraction. This is a loose amniotic bag which is actually by any Cocker's forceps we try to cut off. So by doing this amniotomy, the amniotic fluid is released and ultimately there is within a 3 or 4 hours there is a start of uterine contraction. Now the most commonly which is used for induction of labor are the pharmacological agents. What the pharmacological agents are used? These are commonly are the prostaglandin. For induction of labor, the drug of choice are the prostaglandin. For augmentation of the labor, the drug of choice are the oxytocin. So these two important things which always we have to be remembered. So there are the two types of prostaglandins are available. The one is PGE2 and the second is PGE1. The one or more prostaglandin which we read is PGF2 alpha, that is carbaprost, which is used for the control of the PPH. So we should have to be remember the types of prostaglandin. PGE2 that is a dinoprost and PGE1 that is a misoprostol. This is very important drug for induction of labor. Other are rarely used, only the research point of view important. So what are the prostaglandin? Prostaglandin are the chemical precursor are the arachidonic acid. Prostaglandin are endogenous compound found in the myometrium decidua fetal membrane during the pregnancy. Cervical productions of PGE2, PGI2, PGF, this automatically increases at the term. Prostaglandin administration result in dissolution of the collagen bundle and increase in the submucosal water content of the cervix. So this firm cervix become more pliable and soft because of hygroscopic action of prostaglandin, and what is required, that is we call as a ripening of the cervix. So we all know the ripening of the cervix and uterine contraction. These two things is required for a successful delivery. Unlike oxytocin, response of prostaglandin does not change throughout gestation. And we all know that oxytocin response accelerate but there is the term pregnancy. So what are PGE2, PGE1? PGE2 that is a dinoprost is available are the different forms. Commonly what is vaginal gel, that is a cervi prime. When you come to our labor room, we have a number of induction per day. So what we use PGE2 vaginal gel, that is a commercial name is cervi prime. Other forms are removable tampon, that is a cervidil, or vaginal pessaries are also available in the market. PGE1 that is a misoprostol is actually the tablet. This tablet is used in a different ways, orally, sublingually, vaginally. So these are the different routes of using the misoprostol tablet. So these are the two pharmacological agents used for induction of labor. So what is dinoprostol? Does dinoprostol increases in elastase, glycosaminoglycan, dermatan sulfate and hyaluronic acid. Ultimately leads to increase in the collagenase activity and causes a loosening of the collagen fiber, and increase in the intracellular calcium level leads to the contraction of the myometrial muscle. So both way it acts, it causes a ripening of the cervix by acting on the cervix, and it causes a uterine contraction by increasing in the intracellular calcium and leads to initiation of uterine contraction. Cervical gel, which is commonly used for the cervical ripening, this is actually a pre-filled syringe where around a 2.5 ml syringe of intracervical application of 0.5 milligram of dinoprost is available. So in a one time we are using this pre-filled syringe. This type of a syringe is available in a pre-filled packed manner where the nozzle is fitted to the anterior part and plunger is inserted, and then this nozzle is inserted just at the level of at the cervical canal at the external os, and we insert this amount of dinoprost into the cervical canal, 0.5 milligram of dinoprost. When the woman is supine, the tip of the prefilled syringe is placed intracervically and the gel is deposited just below the internal cervical os. This is very, very important. Normally, in a firm cervix, the internal os is closed. We have to be very much vigilant while inserting the gel. This shouldn't be inserted into the uterine cavity, otherwise there is a chances of hyperstimulation in the patient. So the gel amount should be below the internal cervical os in the cervical canal, not into the more beyond the internal os. So this is an important point. After this application, she remained reclined for 30 minutes. Then after this, she can walk. So this is already I told you how the dinoprost gel is available. Then what we have to do? Once the cervical gel is applied, should only be administered in the hospital. We have to monitor the continuous uterine contraction and fetal heart rate. And there should be the one chart should be maintained once the gel is inserted, and there is a every half an hour we have to record the fetal heart rate and uterine contraction. And normally in a first or second gel, there is a good uterine contraction is occur. Good uterine contraction means occurring of around 2 to 3 contraction for 40 to 45 second in a 10-minute total duration. So if this type of a contraction is occurring, that means the induction is achieved. Then we have to monitor it. If it is not achieved, there is a total relaxed uterus, then we have to repeat the this dinoprostol gel dose in the next 6 hours, and the maximum of 3 doses we can use in a one patient for induction of labor. Then the next is the Cervidil. This is again a dinoprostol gel available. We can insert in the posterior fornix, and normally it start the contraction and we leave it for around 12 hours, and this is a 10 milligram dinoprostol gel. We leave it for 12 hours and then we will remove. In this much of 12 hours, normally the contraction is started. So the hyperstimulation, which I already described you, is a always have to monitor in any induction. So what is that? Occurring of more than 5 contraction in 10 minutes, or any contraction exceed for more than around 2 minutes, it's we call as a hyperstimulation. In these type of hyperstimulation, there is always associated fetal distress, which we always have to be monitored and immediately have to attend these all type of a condition. What the side effect when we insert or using a pharmacological agent? So these are the some non-pharmacological agent have the benefit of not having these all side effects. Pharmacological agent, both the misoprostol and dinoprostol causes nausea, vomiting, diarrhea, and we have to be used cautiously in a glaucoma, hepatic renal disorder, and the asthma. Although these all three are a, not a absolute contraindication, these are a relative contraindication to use of a dinoprost. The next is a misoprostol. So prior to go in a detail of misoprostol, just a brief about a dinoprostol gel and misoprostol drug. We all know the dinoprostol is available in a gel form which require a refrigerator to store. It is a good drug because it causes a start of contraction in a limited fashion and very safe for a maternal and fetal point of view, a dinoprostol. But what is only the drawback of the drug is that it is a costlier drug, required a refrigerator. The newer form is a misoprostol. Misoprostol, if we goes in a history, the misoprostol was used in a gastric ulcer patient, and in a gastric ulcer patient it was noted that it causes a initiation of uterine contraction, from where the drug was adopted, and very recently we got it the FDA approval. So what the this is a drug, very cheap drug, which do not require any refrigerator. Only it causes a very hard, what we can in earliest start the uterine contraction. So this is a very good for a abortion purpose. Although at a term gestation we have to use a misoprostol very carefully. The dose of misoprostol in the term gestation is 25 microgram, or maximum is 50 microgram, not beyond the 25 or 50 we used in a term gestation. Very cheap, easy to store is a very uh, important benefit of misoprostol. Pharmacokinetics is almost similar. It causes a its half life is around 20 to 40 minutes, and excretion mainly occur by the renal. Maximum plasma concentration with 400 microgram misoprostol is noted. 25 microgram at 4 to 6 hour interval is a accepted regime by the AICOG. Maximum 5 to 6 dose is allowed for the induction of labor. And normally in a 1 or 2 dose, it started the uterine contraction. Monitoring of these type of a patient is by the same as we do for a dinoprostol induced patient. Okay, so at the last resort for the induction of labor is a oxytocin. Oxytocin for induction is only used when there is a bishop is good. More than a 6 is when we use the oxytocin as a induction of labor. Otherwise, oxytocin is a preferred drug for the augmentation of the labor. Okay, upper limit of the oxytocin infusion during a labor with a live fetus is 40 milli international unit per minute. Not beyond that, we have to use a oxytocin for induction of labor. The low dose regime is when we use a oxytocin 1 to 2 milli international unit per minute, increase incrementally by 1 to 2 milli unit at every 30-minute interval. And high dose regime is when you start with the 4 to 6 milli international unit, increase to 4 to 6 every 15 to 30 minutes. So low dose, slowly we increase the dose. 1 to 2 is the initial start of the drug, and a high dose we start from 4 to 6 international milli international unit dose. Assessment is the same. Every 4 to 6 hour we assess for the uterine contraction and dilatation of the cervix, and then we take a decision how we have to be progress. We all know that 1 ampule of oxytocin, that is a 1 ml solution, contain 5 unit of oxytocin, and 2 ml of oxytocin is taken in a 10 ml syringe and dilute with the 8 ml of normal saline. So it take a 10 ml solution of 10 unit of oxytocin. 1 ml of this saline contain 1 unit oxytocin. So to make a bottle of 2 unit oxytocin, 2 ml is added to 500 ml of ringer lactate. So this how we make a oxytocin infusion drip, and this is a rate by which we start. In a low dose we start with the 1 milli international unit, that is a 8 drop, then we increase it in the next 15 to 20 minutes to 16, 24, 32, 40, 48, 56 drop. 56, that means 64 drop means 8 milli international unit oxytocin is going on. So this is how we further increase the dose of oxytocin. In every 20 minutes we assess for the uterine contraction, and when it is a good uterine contraction is achieved, that means the same dose we have to be continue, and then monitor the patient in every 4 to 6 hours for the dilatation of the cervix. This is all I already described. So if we want to know with respect to disease about the disorder to the induction of labor, pre-labor rupture of membrane. So we all know it occurs. Induction labor is recommended if there is a pre-labor rupture of membrane more than a 37 week. We all know the initial assessment of the patient, and in these type of a pre-labor rupture of membrane, always have to note the assess the liquor amount, condition of the cervix, and then we plan for the induction of labor. We can use either a dinoprostol or misoprostol after informed consent to a mother. Hypertensive disorder, if it is a gestational control gestational hypertension, we can continue the pregnancy till 40 weeks. If it is an uncontrolled gestational hypertension, severe preeclampsia or eclampsia, it required an induction of labor. Eclampsia required immediate induction of labor, and severe preeclampsia is normally required induction of labor at 37 weeks. Diabetes mellitus, induction of labor is not recommended before 39 weeks with the gestational diabetes mellitus, which is well controlled. Induction of labor is recommended at 38 weeks where the diabetes is controlled on insulin or on oral hypoglycemic agent. For FGR, the FGR, if it is a compromised fetus at 34 weeks, that means a Doppler abnormality with low oligo, the induction is required at 34 weeks, and if it is a normal Doppler with severe FGR, induction is required at around 37 weeks. Twin pregnancy is actually uncomplicated twin pregnancy, no contraindication to vaginal delivery, but there is always the contradictory statement in a induction versus a spontaneous delivery. So in a twin delivery, the decision of induction is very much judicious and depend upon case to case. Obstetric cholestasis, intrahepatic cholestasis of pregnancy required a termination of pregnancy or induction of labor at 37 weeks of gestation. Intrauterine fetal demise after stabilizing mother, counseling required a immediate induction of labor, and these type of a patient usually in a 25% of patient shown the DIC type of a feature, disseminated intravascular coagulopathy. So we always have to be rule out the DIC, complete hemogram and fibrinogen level. These all we have to be assessed prior to the induction. Previous cesarean are actually in a IUD patient where we can do a induction only at a case to case varies. Otherwise, it is even a relative contraindication of induction of labor. Preterm pre-labor rupture of membrane. This again depend upon the what the fetal condition, because it is a premature baby where the decision of induction versus a cesarean section varies as per the case to case. So what the monitoring required at the time of induction? We all know that before induction of labor, non-stress test NST is recommended. Intermittent maternal and fetal monitoring should be done every hourly initially, and then continuous electronic monitoring or more frequent intermittent monitoring should be started when the patient goes into the active labor. Progress of labor to be monitored using a partogram, and close watch is kept for the maternal vital at the time of induction of labor. What is, if these all good, we we all want a healthy delivery at the end, but there is sometime the failed induction. What is this failed induction? What is the failed induction is different from the failed labor progress. So failed induction, that means after a maximum dose of the drug, there is no initiation of uterine contraction. This we call as a failed induction of labor. And what is a failed labor? Failure of labor progress. Once the contraction is good, patient go on into a labor, then because of any problem like problem is a passage passenger or power, it causes a failure in the labor process, which is a different terminology than the failure of induction. Then maternal request for induction of labor. What is this? The maternal request for induction of labor at term for non-medical reason should not be entertained, as it is an unnecessary intervention except under exceptional circumstances. So we shouldn't have to be more given a priority of these type of a statement. The pain relief at the time of induction, women should be informed of availability of pain relief option. Women should encourage to use a breathing relaxing technique at the time of labor. There is no need to wait for labor anesthesia abruptly till the cervical dilatation reaches up to 4 to 5, and if given early in labor, it does not affect the progress of labor. So we can give any of the painkiller as per the choice of the patient. Pethidine or opioid analgesics can be used for a short-term pain relief, preferably in the early labor. Complication already describe you. The uterine hyperstimulation, uterine rupture are the important complication at the induction of labor. Counseling part I already described. This is the important aspect. Always prior to taken for the induction of labor, good counseling is a part of need. This is all about the induction of labor. Thank you so much.